Hi, it's David Liew here from sunny Barcelona for EULAR 2025. Good to be back in the midst of EULAR. It's all been hectic today. It's been really interesting GCA PMR session today. Some controversial bits with it, with a abstract getting turned around in terms of the numbers compared to what was previously reported. But I want to tell you a little bit about GCA and infection. It's because I've heard so much said about JAK inhibitors, upadacitinib, and infection risk in older people. And people's reticence to consider it because of risk and balancing that up against steroid, which is what the name of the game is in GCA, being able to reduce down steroid exposure. That's why we think about things like upadacitinib. Well, we saw an analysis from the Select GCA study, which you might remember previously reported at ACR and EULAR last year, and led to the approval of upadacitinib for giant cell arteritis. In that study, it looked at upadacitinib at two different doses, 7.5 and 15 milligrams a day, with a 26-week taper in giant cell arteritis versus placebo with a 52-week taper. So that is to say, the second 6 months of that study period, you've got two sets of patients getting JAK inhibitors and one other arm getting the end of a steroid taper. And what we saw at this meeting was actually an analysis about infection in those arms over that time. And it's really fascinating because that gives you an idea about essentially steroid, tapering steroids, so relatively lower doses of steroid, but in monotherapy versus JAK inhibitors in monotherapy, and seeing how they paired up in terms of infection. And what's telling is that serious infections wasn't quite significant, but it trended heavily towards favoring the JAK inhibitor compared to what I think a lot of people would have anticipated. Zoster the other way, and we know that Zoster's a bit of a risk with JAK inhibitors. But really, if we're talking about general infection, and that's where the bulk of the morbidity is, then we're talking about upadacitinib well and truly, well, trending at least to a substantive difference over what we saw with steroids. Now, I've got a talk tomorrow about whether JAK inhibitors have a greater infection risk than biologics. And I think the real message out of any of this is that the best thing that you can do for reducing infection risk in our patients is to reduce the steroid. That's an important message that we should never forget in amongst the bluster about infection risks from any DMARD. For plenty more about all the latest that's going on at this wonderful meeting, you know what to do. Head down to roomnow.com.